Okay, let's start. It's really a pleasure for me to talk now about the spiration valve therapy, and I want to discuss the question how to improve quality of life of our emphysema patients. So these are my conflicts of interests. I want to start with one case report. I want to report about a 70-year-old female patient with a chronic obstructive pulmonary disease known since 2016. She has got a very severe COPD called 4 Group E. She reported a breathlessness on exertion with a modified medical research council of 4 points, and she reported 2 exacerbations per year. This patient has already in respiratory failure. She was on long-term oxygen therapy, and she had also a non-invasive ventilation for hypercapnia. She stopped smoking in 2017. Her medical treatment was optimal. She has got some comorbidities like an osteoporosis and an arterial hypertension. Now I want to show you the lung function of this patient. She has got a very severe obstructive ventilatory disorder with an FEV1 of 27% of predicted, and she was severely hyperinflated with a residual volume of 279% of predicted. In this slide, you can see the CT scan of the patient, and you can see very clearly that the patient has got a lower lobe predominant emphysema. So let's discuss how can we treat this patient. In general, the COPD can be treated by different therapeutic approaches. Of course, smoking cessation, rehabilitation, vaccination are the first steps for the COPD treatment. A medical treatment should be referred to the patient based on the group A, B, and E. And the patients with a respiratory failure can undergo a long-term oxygen therapy or a non-invasive ventilation in case of hypercapnia. Of course, we also have got some surgical approaches like lung transplantation or also the lung volume reduction surgery. But now I want to focus a little bit more on the endoscopic treatment. So far, we have got different endoscopic approaches to achieve a lung volume reduction. So you can see here there is a valve treatment, but we also have got the polymeric lung volume reduction, the bronchoscopic thermal vapor ablation, and the coil implantation. We can also combine the polymeric lung volume reduction with the valve treatment. So we can divide these different therapeutic approaches in 2 big groups. We have got the blocking devices, that are the valves, and the other techniques are summarized to the non-blocking devices. There are some advantages and disadvantages. So the valves are the only reversible technique, but they are only efficient in some patients who have got an absent collateral ventilation. However, the other technique, the non-blocking techniques, are irreversible techniques, but they can also be used in patients with a significant interlobar collateral ventilation. However, there are also some adverse events experienced when we perform bronchoscopic thermal vapor ablations sometimes, or of course, or also the coil implantation. So my recommendation is to perform these treatments only within a clinical trial. So now let's focus on the endoscopic valve treatment. How do the valves work? The valves are one-way valves that are implanted in the airways of the most emphysematous-destroyed lung lobe. And the valves allow the air to be expelled during expiration, but not to come in during inspiration, and thus facilitating a lobar atelectasis, and thus a lung volume reduction. But who is now a candidate for an endoscopic lung volume reduction? We cannot treat all the COPD patients effectively by the valves. So my first step is always to look at the lung function. So the patients should have an FEV1 between 15 and 50% of predicted, and the patient should be severely hyperinflated with a residual volume of more than 175%. But we know the higher the residual volume, the better the outcome of the patients. So I treat preferably the patients who have gotten a residual volume of more than 200% or more than 220% of predicted. The second step is to look at the exercise capacity, and you can measure it by doing a 6-minute walk test. And the 6-minute walk test should be between 100 and 500 meters. But of course, if you have got a patient with a 6-minute walk test of 90 meters, something like that, this is not an absolute contraindication for an endoscopic valve treatment. And my third step is to have a closer look at the CT scan. The CT scan should confirm that the patient has got a very severe emphysema. And then I look for the target lobe for the endoscopic lung volume reduction. The target lobe is the most emphysematous destructed lobe. Then you have to look for the emphysema distribution. Does the patient have got a heterogeneous emphysema or a homogeneous emphysema distribution? Nowadays, we know that we can also treat the patient with a homogeneous emphysema effectively by the valves, but we also know that the patient with a heterogeneous emphysema have a superior response to the valve treatment. Then you also have to look for the contraindications. For example, if the CT reveals a pulmonary nodule that is suspicious for lung cancer, this patient is not a perfect candidate for an endoscopic valve treatment. And at least you should have a look on the fissure integrity. And I want to explain the term fissure integrity a little bit more closely. The fissure integrity is the surrogate for an collateral ventilation. So I want to explain it with 2 examples. So this is my first example. This is a patient with a very severe emphysema in the left lower lobe, and the left major fissure is absolutely complete. So we treat the left lower lobe by the interbronchial valves, and then the volume of the left lower lobe decreases, whereas the volume of the adjacent healthier left upper lobe increase. And this patient will benefit from the interbronchial valves. However, my second case, the patient has got also an emphysema that is predominantly in the left lower lobe, but this patient has got incomplete fissures. So when you now implant the valves into the left lower lobe, the patient will not benefit because there's no volume shift, because the left lower lobe can be refilled through the parenchymal bridge between the left upper lobe and the left lower lobe. And this is why the patient will not experience any benefit from the valve treatment. So we should only treat the patients with a complete interlobar fissure. In this slide, I summarize all the randomized controlled trials published to the endoscopic valve treatment. And these are now the first trials. When you have now a look at the outcome measures, you can see that the patient experienced a statistically significant improvement in FEV1 6-minute walk test and also health-related quality of life measured by the St. George Respiratory Questionnaire. But you can see it is only of uncertain clinical relevance. But we have learned a lot from these randomized controlled trials. So we have learned that only the patients with a complete interlobar fissure can be effectively treated by the valves. So in the following randomized controlled trials, only the patients with a complete fissure were treated by the valves. And now when you have a look to the clinical outcome measures, you can see that the patients then experience really a substantial benefit from the endoscopic valve treatment. Now, how to quantify the collateral ventilation, because it's so crucial for the response to the valve treatment. There are 2 different options how to quantify the interlobar collateral ventilation. The first option is to perform a CT fissure analysis. So the radiologist should have a very close look to the fissure integrity. But there are also a lot of softwares that support you. The software shows you the target lobe for the valve treatment, and the software also shows you the fissure integrity. And the second option is to perform a Chartis measurement. That is an invasive measurement during a bronchoscopy. For the Chartis measurement, you introduce the catheter into the lung lobe that you want to occlude by the valves. At the distal tip of the catheter, there's a balloon that can be inflated so that the target lung lobe is isolated. And then you can measure the airflow coming from this target lobe. And when the airflow decreases over the time of the measurement, that should last 6 minutes, then the patient has got no significant interlobar collateral ventilation, and this patient will benefit from the interbronchial valve treatment. However, if the airflow does not decrease over the time of the measurement, then the patient will not benefit from the interbronchial valves, and you should not place some interbronchial valves. In most cases, you should combine these 2 different methods, the CT fissure analysis and also the Chartis measurement. But it depends also on the site you want to treat. First, let's have a look at the left of the left lung. So if the left major fissure integrity is more than 95%, you don't have to perform an additional Chartis measurement. You can go straight forward and you can implant some valves. However, if the left major fissure integrity is between 80 and 95%, then you have to perform an additional Chartis measurement, and only if the Chartis measurement confirms that the patient has got no significant interlobar collateral ventilation, then you should implant some valves. Looking at the right side, it's a little bit more complicated because you should always perform an additional Chartis measurement when the fissure integrity is more than 90%. When the fissure integrity is less than 90%, then the patient is not a perfect candidate for the valve treatment. Besides the absence of an interlobar collateral ventilation, there are more predictors for a successful outcome following the valve implantation. For example, the heterogeneous emphysema distribution, I have already mentioned it before, that also the patient with homogeneous emphysema can be treated by the valves, but we know that the patient who have got an heterogeneous emphysema distribution have got a superior response to the valve treatment. But also, the higher the emphysematous destruction of the target lobe, the higher the air trapping, the lower the target lobe perfusion, the better the outcome of the patient. And we also know the higher the residual volume in the lung function test, the better is the outcome of the patient, and also the lower the exercise capacity. Now let's talk a little bit about the implantation itself. So the interbronchial valve is available in 4 different sizes, 5, 6, 7, and 9 millimeters. When you perform a lot of procedures, then you can estimate which size you have to take for occluding one airway. But if you don't do so many procedures, there's also one catheter that helps you to estimate the size of the valve that you should use to occlude one airway. So this is a measurement kit, and you advance the catheter into the airway that you want to occlude by the interbronchial valves. And the distal tip of this measurement catheter, there's a balloon that can be filled with saline. And depending on the volume of the saline in the balloon, you can take the accordingly size of the valve. In this movie, I want to show you now how to implant the valves. You have got a special delivery catheter that is introduced to the working channel of the flexible bronchoscope. And you can see here the yellow ring that helps you for positioning of the catheter into the airway, and then you can deliver this interbronchial valve very easily. The most important thing is that you occlude one lung lobe completely, otherwise the patient will not experience any benefit. So if the patient fulfills all these predictors, then you will achieve a success of the valve treatment. I only want to show you one randomized controlled trial related to the interbronchial valve placement a little bit more in detail. So this was a randomized controlled trial that was published by Kramer in 2019. 113 patients underwent the valve treatment and 59 patients received the medical treatment. The primary outcome was the FEV1. You can see here very clearly that the patients who underwent the valve treatment had a very good outcome compared to the patient who underwent the medical treatment. And there are also 2 retrospective trials that confirmed that the patients who experienced a complete lobe atelectasis following the valve treatment has got also a survival benefit. Now some words to the high-risk patient. What patient is a high-risk patient? That are the patients with a low FEV1. That means an FEV1 less than 20%. And these retrospective trials showed us that we can also treat these patients with an FEV1 less than 20% very safely by the valves. The same was observed with the patients with a very low DLCO. Patients with a diffusion capacity less than 20% can also be treated safely by the valves. And the last high-risk patient group are the patients who are hypercapnic. Also, these patients can be treated safely by the valves. And moreover, the hypercapnia improved after the valve treatment. Also, the endoscopic valve treatment is a minimally invasive treatment approach we can observe some complications. And I want to talk about one complication a little bit more in detail because we often observe this complication. I'm talking about the pneumothorax. So when you look at the first randomized controlled trial, the pneumothorax rate was found to be 4.2%. So it's not quite high. But if you now look at the latest randomized controlled trials, we have a pneumothorax rate of 34%. So why did the pneumothorax rate increase over the time? So in 2010, 2011, we started to perform a fissure integrity analysis. So obviously, the patients with a complete fissure are not only the perfect candidates of the very good outcome, they are also at a very high risk for experiencing a pneumothorax. But then we can hypothesize that the patients who experience a pneumothorax will nevertheless have got a benefit from the valve treatment. And we could confirm this in one retrospective trial. So these are now the patients who still had a complete lobe atelectasis after the pneumothorax and after recovering from the pneumothorax. And you can see that these patients really had gotten a substantial benefit from the valve treatment. But of course, the pneumothorax is a complication and we have to know how to manage the pneumothorax. And it's also really very important to know that the highest rate of pneumothorax is within the first 3 days after the valve implantation. So it's really, really crucial that you hospitalize your patients for 72 hours following the valve implantation. How to manage the pneumothorax? So the first step is to insert a chest tube, and sometimes you also need a second chest tube because the fistula is sometimes very, very high. The fistula volume is very high. The second step is when the pneumothorax is still ongoing, the lung is still collapsed, then you should also remove the valves. And the third step is when does not help, so when the chest tube does not seal the fistula and also not the valve removal, then you should also discuss with the thoracic surgeons to perform a video-assisted thoracoscopy with a fluidesis to seal the fistula. Now let's go back to our case. I started with this case. Again, the CT scan or the statistics analysis of this patient, you see the patient has got clearly a lower lobe predominant emphysema, and the fissure on the right-hand side is complete. You can see here the emphysema index, so the patient has got an emphysema index of 38% in the right lower lobe, and the emphysema index was 23% in the left lower lobe. So we decided to perform a valve implantation in the right lower lobe after confirmation with the Chartis measurement that this patient was CV negative. And then we implanted some interbronchial valves to occlude the right lower lobe. And this is now the chest X-ray prior to the valve implantation, and this is a chest X-ray immediately following the valve implantation. And you can see here that there's a little bit of atelectasis ongoing, and the patient has got also a small pleural effusion that is normal. When the patients experience an atelectasis, you often observe also a small pleural effusion. So the patient came back 4 weeks following the valve implantation, and the lung function improved. So the RVB1 increased from 27% to 44%, and the residual volume decreased from 279% to 233%, and the patient was really very happy. So what is my take-home message? I think we can treat our patients safely by the valves, but we have to perform a precise patient selection. It's really very crucial that you figure out what is the most emphysema-destroyed lung lobe, that you look very closely at the fissure integrity. And of course, an adequate treatment is really very crucial. You have to find the correct valve size for the treatment, and it's really important that you know how to manage the complications following the valve implantation, particularly the pneumothorax. Thank you so much for your attention. You can ask your questions.
Thank you very much, Daniela. Does anyone have any questions to ask? Please let me know, and I'll come and join you with the microphone. No? You have a question? Thank you.
Thanks very much for that. Just wondering with regards to when you have placed the valves and you do have a pneumothorax, what proportion of people do you find you have to remove the valves or just manage with chest tube?
Yeah, very good question. So 87% of the patients who experience a pneumothorax have to undergo a chest tube insertion. And out of these patients, 44 patients have to be the valve removed again. So 44% of the patients who had got a chest tube. And at a very early, so in 2015, 2016, we also sent 20% of the patients to the thoracic surgeons, but we have learned a lot. So I think it's maybe 5% of the patients who are sent to the thoracic surgeons because we have learned to wait. So when the pleural have got contact again, then you can wait. Only when the lung is collapsed, then you should talk to the thoracic surgeons.
Any more questions? Another one?
Sorry, just to follow up from that one, would you re-challenge them with further valves if you have such mischief on a first try?
Sorry, I did not.
Would you re-challenge? So if you have a patient where you have to remove the valves, would you then re-challenge them once they have...
After pneumothorax, you
yes,
mean?
yes.
Yes. It depends on the wishes of the patient. And because the patient has got, again, the same risk of pneumothorax. So I ask the patient, and there are a proportion of patients who say, yes, I will try it again, because prior to the experience of the pneumothorax, I felt very well. And then I go on and I put some valves again. But when the patient is a little bit anxious, I do not.
Hi, thank you very much. It's very interesting. I didn't understand. You're putting all the valves in the lobe for closing the lobe in one time, because we are doing in our hospital in France. In France, we are doing a little bit, and after we are closing the lobe in 2 times, 1 month after. How are you doing?
Yeah.
It's 1 time or 2 times?
Yeah.
Thank you very much.
A very good question. So normally I put all the valves in one time in one lobe to occlude one lobe. There are some trials that figured out that when you do a sequential implantation of the valves, that then the pneumothorax risk is decreased a little bit. But we could not confirm it in other trials. So the trials are a little bit controversial. So far I do it in one procedure.
Any more questions? Another one.
And if you have a patient with pneumothorax and you will remove all the valves, you are thinking for the second one to do it sequential?
That's a very good point. We can discuss it, yes. We should discuss it for a study. A very good point, yes.
Okay. Well, thank you very much, Daniela, for that very informative talk. Thank you very much.